So when I'm assessing the upper cervical spine, specifically the OA joint, what I'm first looking at is posture. Most people have a little bit of a forward head posture and a rounded thoracic spine. Sometimes if it's excessive though, the OA joint is sitting in a anteriorly translated, posteriorly rotated position. And they've lost the posterior rotation and the flexion component. Actually, that's the typical, I would say. Most people, due to postural factors, lack that range of motion or that joint mobility. It's very rare to see a loss of anterior rotation. It typically happens after some sort of traumatic incident rather than just due to day-to-day life activities. I'm going to get the client to do a chin tuck for me and then also a chin poke. And what I'm watching for is symmetry. So you can go back to neutral. For example, if the OA joint on chin tuck has a bit of a deviation to the right, for example, that would suggest to me that the right is posterior gliding, but maybe the left is not. So I'm watching the chin in midline to see where it sits. Same on chin poke. If there's a bit of a deviation to the right again, let's say, then that would indicate that maybe the right is not moving anteriorly where the left is, and that causing that deviation to happen. So you can also look at a little bit of nod to assess the translation in side flexion. So instead of a full side flexion, the person is just going to try to bring their ear to the side of their neck. Yeah. And to the other side. And there's a little less on that side as well. There was also a slight deviation on his chin tuck. We got the client lying in supine. We're going to check the passive physiological and the passive accessory motion. So just going to do a little chin tucking position again. I'm stabilizing C1 with a lumbrical grip with my right hand. I'm cupping the occiput with my left and just doing that posterior rock and translation. More of a passive movement than an actual joint glide. I'm going to maintain the same position and actually produce a posterior joint glide. This is more just straight posterior now at the end of range of motion. We don't generally get to the full end joint glide when we do that symmetrically on both sides though too. So for the OA joint, to get the full excursion of joint play, what we have to do is side flex and rotate in contralateral directions. So if I want to assess the right joint, well, for this purposes of this, I'll assess the left joint. If I want to assess the left joint, what I'm going to have to do is add a combination of right side flexion and left rotation with chin tuck and that posterior translation that I just did. Okay, so same grip, except I'm going to move my hand a little bit more over to the left mastoid region. I'm going to right side flex, left rotate, flex, and then now add my posterior glide to assess that full extent of range of motion or passive accessory movement there. That would be, if I found restriction, that would be where I would want to be treating and mobilizing my graded mobilizations as well. So the OA joint, basically responsible for the nodding. We can see potentially deviations when we do active range of motion tests. As I said, most people posturally are prone to issues with a loss of posterior glide, and then I showed you how to assess symmetrical or bilateral posterior glide, and then to get more into a end range unilateral glide. And those would be for both assessment and your mobilizing positions.